Okay, we're going to go ahead and get started this morning. Good morning to everyone, and thank you for joining us today. I'm very excited on a personal note to have our speaker do this presentation today because I actually have a dog that was diagnosed with a pretty rare brain tumor. And Dr. Moeser is a neurologist that had a chance to see him and actually give us that diagnosis for us to go forward. And so, of course, I took advantage of the opportunity to hook him into helping us by talking to us about canine movement disorders. Just a couple things before I introduce Dr. Moeser. As you can see on the screen, I just have a few housekeeping details up there for you. And I'm not going to read the slide to you, just basically know that if you have any questions, please go ahead and put them in either the chat section or the Q&A section. And that little toolbar should be either at the bottom or the top of your screen. Um, and then we will probably take those questions at the end of the presentation, just so that Dr. Moeser can get through his content. Um, because you are on, if you have your camera on, your face will be recorded in part of the presentation. So if you don't want to be seen, just switch that in your upper right-hand corner and make sure that you are muted until the time for the questions and answers section. So we're going to go ahead and get started. Dr. Moeser is a 2009 graduate of University of Wisconsin School of Veterinary Medicine. Following graduation, he did a one-year small animal rotating internship in the Illinois, actually in the Chicago area. And he was actually named Intern of the Year and accepted into a neurology fellowship or residency at the University of Pennsylvania. Immediately after completing that residency, he moved to the Detroit area and worked at Medivet Commerce, formerly known as Animal Neurology and MRI Center. Sorry, I should put my glasses on here. And he worked as a veterinary neurologist until 2003. He's done a lot of things, and when I was looking back at some information about him, it's very clear to me, and I think that he likes to do some teaching as well. I saw some examples of some presentations that he has been given, so I'm really excited to have him here. He and his wife are both, I love this, lifelong cheeseheads. Yay. And are very excited to be back in the Badger State. And so we're really happy to have him here. I'm delighted that he's literally less than a 3-hour drive from Door County Scotty Rally headquarters. So I'm really happy to have him here. We're going to go ahead and change screens here. So just give us just a moment. You should be able to switch to your screen there.
All right. 1 second here. Should be. All right. Can everybody see the PowerPoint screen?
Yep.
Yep, absolutely.
Yep.
Thank
Yes.
you.
Can.
Can you
All
see
right.
can you see his screen?
Yes, it says canine movement disorders. We've got it.
Perfect.
All right. Perfect.
I just need to
Well,
get
oh
it.
yeah, go ahead.
Hang on 1 second. Can you guys still see it?
Yes.
Yes.
Okay,
Yes. Yeah.
perfect. Okay,
All right. Well, I'm so honored to have been invited here. So thank you for having me, and thanks everyone for taking some time out of your precious weekends to be with us. So yeah, I've been invited to talk about um, still a pretty mysterious aspect of veterinary neurology, but we are learning more all the time. Canine movement disorders. All right, let me just yeah, just wanted to show you a picture of still fairly new building here in Mequon, Wisconsin. We just opened in November of 2023. And we do only small animal veterinary neurology. We have a in-house MRI, in-house surgical suite. We hospitalize our neurology patients, and it's really been a wonderful experience from the ground up and growing, and really proud of my team and proud to be here. So a lot of this has already been stated in a very gracious introduction, so thank you. But yes, I am a Badger. I grew up in the Milwaukee area. I attended the University of Wisconsin School of Veterinary Medicine, followed by an internship where I spent some time in Aurora, just about 45 minutes west of Chicago. And the other 50% of my internship was spent much closer to the city, in Berwyn, Illinois. And after that, I did my neurology neurosurgery residency at the University of Pennsylvania in Philadelphia. And as was mentioned, I was hired in 2013 to move out to the Detroit suburbs in Commerce, Michigan. And it was very similar to what I have right now. At first, just neurology. And that's when it was Animal Neurology and MRI Center. And in 2017, MedVet purchased the hospital, and it became much more of the traditional multi-specialty hospital. And then in 2023, my wife and I decided to move back home to Wisconsin, and that's when we opened up Wisconsin Veterinary Neurology and Surgical Center. So, what are movement disorders? They're still somewhat of an enigma. Sometimes they're difficult to really, diagnose it at sometimes, or at least differentiate from other neurological disorders such as seizures. But they're a group of clinical disorders characterized by involuntary movements without loss of consciousness. But this can be really similar to seizures. And in the clinical setting, we often struggle to distinguish, whether our patients are having a movement disorder or whether they're actually experiencing some form of epilepsy or seizure disorder. Within a lot of, the terminology that we're using now comes from a recent consensus statement that was published by the American College of Veterinary Internal Medicine, and one of their goals was, how can we get everybody to speak the same language on these movement disorders, in the hope that not only will we be able to identify what we're seeing and be able to talk to each other, but then also, maybe we can look to what's happening in human medicine and benefit from the research that's already been done there to help us identify genetic mutations, et cetera. But we've decided to really try to discuss these disorders in terms of tremors, peripheral nerve hyperexcitability disorders, paroxysmal dyskinesias, and dystonia. And just as an example of, how difficult it can be to really know whether we're dealing with a seizure disorder or a movement disorder, I just want to go over one case example. And I think it's, when you get that typical canine or even feline that's having the, what is known as a grand mal seizure, or more accurately called a generalized tonic-clonic seizure, that's easy. They're on their side, they're paddling, or they're stiff. They're oftentimes experiencing autonomic symptoms. And what I mean by that is they urinate, they vomit, they drool, they may defecate. And then oftentimes they experience either pre-ictal or post-ictal behavioral changes. And that might be, sedation, ataxia, like a wobbly gait, They may want to be by your side, more than normal. So when we see that, it's pretty easy. We know what we're looking at. But sometimes there's no preictal or postictal behavioral changes. There's no autonomic signs. Like they might just lift up a leg and stand there for a second, stare into space. And it becomes much more difficult for us to know, is that a partial seizure, or are we dealing with some sort of, movement disorder? And I think that's one of the more difficult parts of small animal veterinary medicine right now. And that's why I think it's so important, the work that's being done now, just getting a baseline on what words do we use to describe these disorders, and how do we talk about them? So this was a case that I recently saw. Bella, she's an 8-year-old female spayed Australian Shepherd, and she was coming in for, just sometimes, most of the time she was normal, but every once in a while she would just sit down. And what made this difficult, the owner is an MD, very busy, didn't have time to bring Bella in. So they had a caretaker bring Bella in. And so some of the information I'm getting is secondhand, but what was kind of being described to me would be that she was sitting down intermittently. Her hind legs would become really rigid and stiff. But then after 30 seconds to a minute, she would get up and she'd be normal. And there was nothing, she would run, she would jump, until she had another one of these episodes. And so we didn't really know, were we dealing with arthritis of the hips? Were we dealing with a disc herniation, like in the T3L3 or L4S2 region? The neuro exam was normal, no pain on palpation of the vertebral column. We did an MRI and because we didn't know if we were dealing with seizures or something going on with the spine, we actually did an MRI of the entire spine. These are just sagittal MRI images. The one on the left is of the cervical spine. The one on the right is a sagittal of the brain, but everything came back normal. We didn't find any disc herniations. We didn't find any tumors, nothing that would cause this dog pain, and nothing in the brain that would cause seizures. CSF tap was normal as well. So we tried different medications. We tried we did pain med trials, carprofen. We tried levetiracetam or Keppra, which is an anticonvulsant. And, the carprofen maybe helped the dog. The owner thought that the dog was just maybe a little bit more active, but these episodes were still occurring. And then this just kind of goes to the point of how helpful it can be just to literally see the episode. If we're just trying to diagnose based on the history in the exam room, it can be very difficult. So this is Bella, and this is what she does. So it's very different from what I originally thought was going on. And so we'll just watch that one more time. And so after seeing that, we decided to, that maybe this was some sort of movement disorder. And we actually finally put her on zonisamide. And zonisamide is an anticonvulsant, but it also has carbonic anhydrase inhibitor properties, very similar to acetazolamide, which you may have heard of and we'll talk about that a little bit later. Acetazolamide is one of the drugs that we find helpful for certain paroxysmal dyskinesias, like in the soft-coated Wheaten Terrier. Well, zonisamide has properties similar, and so we put Bella on that, and these episodes went away. And so I guess you could still argue that maybe Bella was responding to the anticonvulsant properties of that medication. But, we had previously tried levetiracetam, and, so I truly think that Bella's experiencing some sort of paroxysmal dyskinesia, and that she's responding to the carbonic anhydrase inhibitor properties of that drug. And then another kind of example here, Bodhi. I just saw Bodhi, a 4-year-old male neutered French bulldog. He came in for a 2-week history of every day, sometimes several times a day, he would just start the owner knew when it was coming on, he would just start kind of circling to the right. It was always to the right, never goes to the left. And then he'll suddenly just kind of fall down on his left hip. He'll urinate. He'll start yelping. It usually only lasts like 10 seconds, maybe 30 seconds. And then he gets up and he seems fine. His exam was also normal. Being a Frenchie, we thought, well, this has got to be a disc herniation or myelitis. You know, it's what's most common in Frenchies. And we performed an MRI, we performed a CSF tap, and we couldn't find anything. And here's a video. So this is just kind of an example of how it starts. Bodhi just kind of circles, and we'll watch this for a minute. And in this video, he doesn't scream or yelp. So this was one of the more mild, but he'll just do this. He gets to a point where he just kind of falls and drags himself on the ground. And then after 10 seconds, 30 seconds, you know, he gets up and walks away. And so this is what the owner is experiencing. And we ended up trying an anticonvulsant levetiracetam, and it actually did help Bodhi. So we believe Bodhi is undergoing some sort of complex partial seizure. And the point of those two videos is just to kind of show how similar a seizure and what we're calling movement disorders are. And quite honestly, I think we're not always right. You know, for example, we might put a dog on zonisamide and they get better, and we think that we're treating a movement disorder, but maybe we're still treating some sort of epilepsy. And you know, it's just why it's so important that we continue researching these disorders and you know, come up with the same terminology, and hopefully in the near future, especially with mapping of the canine genome, hopefully we start finding more genetic mutations and we can better diagnose some of these disorders definitively. So again, movement disorders or dyskinesias are neurologic conditions characterized by abnormal and involuntary muscle contraction relaxation generated by abnormalities in either the central or peripheral nervous system. But that definition is, again, very similar to what an epileptic seizure is, you know, which are excessive, synchronous, usually self-limiting epileptic activity of neurons in the brain. And, you know, it would be great if we could just stick an EEG on all of these dogs. But the problem with that is you would need to have that EEG on them during the episode. And, you know, for you or I, if we were experiencing a seizure disorder, they may have us go sleep several nights in a epilepsy center where they're monitoring our EEG that entire time. So they're more likely to catch the episodes. That's certainly much more difficult in the veterinary setting. And then the other thing is, you know, a lot of the EEG equipment, you know, requires putting little needles under the skin. And so that, you know, that may require sedation of the patient. And obviously sedating an animal for days at a time may not be ideal. So there's a lot of barriers to definitively characterizing it as a seizure or a movement disorder based on EEG. And then that leaves us with, well, what do we do in the veterinary setting? Well, certainly if I have a patient coming in who's doing something weird and they're of a certain breed, let's say a soft-coated Wheaten Terrier or a Jack Russell Terrier, a breed that's known to have a movement disorder that's been described in the literature, that's going to, turn on a light. Maybe I want to consider that a little bit more. There are certain genetic mutations that have been discovered in these breeds, and if that's the case, if you're kind of stuck and you don't know where to go, some of these genetic mutations you can test for them. There's commercially available tests that you can send out, either cheek swabs, blood, to test for them. EEG, it's possible, just not very readily available, not very convenient. As we saw before, just getting video of these episodes, or sometimes like, for example, with Scotties, the Scotty cramp is oftentimes brought on by excitement, stress, activity. So it's not that unusual if, when you're in the exam room, a lot of these patients are stressed out and anxious, and you might be fortunate enough to see an episode in the exam room. And then finally, drug trials. So if you really think it's a seizure, maybe we try phenobarbital or levetiracetam. If we really think it's a movement disorder, we might try acetazolamide. For some of these disorders like Scotty cramp, we might actually put them on things like fluoxetine or Prozac. And some of these things like acetazolamide or Prozac, we wouldn't really expect to help with a seizure disorder. So if you're trying those drugs and they get better, I think that provides good evidence that we're dealing with some sort of dyskinesia or movement disorder. So moving into the movement disorders, and we try to, a lot of this there with the group that was responsible for coming up with the consensus statement on terminology for movement disorders. They are trying to take the terms that are used in human medicine and apply them the best they can to veterinary medicine, because one of the goals of this is developing animal models that can be used for research in humans as well. And so if we're speaking the same language, that's very helpful. But sometimes it doesn't apply. We are much more dexterous with our fingers and versus quadrupeds. And so some of the movements that movement disorders and phenotypes or physical manifestations of these diseases that happen in people, it's hard to directly apply that to dogs or cats who don't have the dexterity in their digits like we do in our fingers, etc. And so it may not apply. And then there's things like with a tremor, for example, we don't really have anything reported in the veterinary literature for a tremor that happens solely at rest, that would be classified as a movement disorder. But we do have action related tremors. For example, primary orthostatic tremors or canine idiopathic head tremor syndrome. So with orthostatic tremors, these are they're action related, and that meaning that they tend to occur when the muscles that are involved in maintaining posture are being used by the patient. But when they're lying down, or even when these guys aren't just maintaining posture, but they're actually moving or walking, running, oftentimes these tremors will disappear completely. The primary orthostatic tremors tend to occur first in young purebred, large, giant breed dogs. So we're talking like a Great Dane, for example. There are treatments that can be applied, and they oftentimes do help, but they don't necessarily resolve the condition completely. So those treatments that have been tried and have shown some benefit include gabapentin or pregabalin, and I've kind of clumped those together just because they have a similar mechanism of action. Phenobarbital or primidone, I've clumped those together because primidone is actually metabolized to phenobarbital after being given, or clonazepam. And again, they don't necessarily resolve the condition, but they may decrease the severity of symptoms. Labs tend to be a little bit different, and maybe it's a different disease, but the tremor tends to the onset tends to be at a little bit of an older age. They don't necessarily respond to treatment as favorably, but it also tends to be just a more mild form than maybe in some of the giant breeds like Great Danes. Okay. I'm hoping you guys see this. I'm gonna scroll down here real quick. So this is a Great Dane who has orthostatic tremor, and you can just see when he stops moving, his legs start tremoring a lot. It's so much that sometimes he wants to just lie down. And we'll get him up again. But when he's walking around, he doesn't tremor as much. And you'll see here in a little bit, the handler is actually gonna, kind of run or jog with this guy, and he has a much more, when he's moving more rapidly, he has a much more fluid gait than if he's walking slowly or trying to stand. And I want to pay tribute to Dr. De La Junta and Cornell University. These videos are from Dr. De La Junta's time at Cornell. He put together a wonderful video library that's kind of open access. So if you ever want to look for some of these videos, just type in Cornell neuro videos into Google, and there's a ton of videos that he cataloged during his career, and I'm super grateful to him and all of his colleagues, because these are the videos that are very helpful for teaching. And then so you can see here, like when he's actually trotting or running, he looks pretty normal. It's incredible to think that this is the same dog that we were just watching before. And then here he is on the treadmill. He's you wouldn't think this was that the dog we saw in the first part of the video would be able to do this. All right. So I'm going to stop that. Put this down here. Okay. And then another pretty common disorder that I think this one out of all of these movement disorders, I probably see this one the most. It gets sent to me by veterinarians as seizures. They don't. So head bobbers syndrome is a popular name for this, but other names for it include canine idiopathic head tremor syndrome, or postural repetitive myoclonus. Again, we tend to see this onset in younger dogs. Again, there does seem to be a breed predisposition. So, for example, English bulldogs, Dobermans, Labs, but really you could see it in any dog. I've seen it in a lot of different breeds, but those are going to be some of the more common ones. And they're totally aware of their surroundings. They don't have any sort of autonomic sign. They don't seem to be in any distress. It's just usually their head has this very high frequency tremor or shake, either side to side or up and down. And we don't think that these dogs are experiencing any sort of seizure, we think that we're not totally sure yet, but we think that it has something to do with the stretch receptors in the cervical region, or the cervical spine. And one of the reasons for that is these tremors oftentimes are happening when the patient is resting and they have their head or neck in a certain position. And then if you either, let's say, like put a pillow under their neck or distract them with a toy. I oftentimes ask my clients to give them a Kong filled with their favorite treat, something for them to do, or even get them up and take them for a walk, and see if you can stop the tremor. Because if this were truly a seizure, you shouldn't be able to change, or stop the seizure with a simple activity like getting them up and taking them for a walk. So this is, I use this actually more as like a diagnostic. They come in, rather than spending thousands of dollars on an MRI to see if there's something going on in the brain, doing a spinal tap. One of the first things I'll do is say, go home, try these things, try to interrupt the episode by distracting them. And if you can routinely do that, it's really probably not a seizure, and it's probably not worth spending all that money. But here is an example of a short clip of a dog doing this. And you could see why the clients would be, but you see, as soon as he pops up, it stops. And he's completely aware of his surroundings. We'll watch that one more time. So he is having more of a vertical up and down head tremor, but it can just as easily be side to side. And with these dogs, we don't do anything. I'll have the owners try to change the, to distract the patient at the beginning. And that's more to provide me with, the knowledge that, yes, we're not dealing with a seizure. I don't need to worry about doing an MRI. But once we've made that determination, usually I just tell families, just let them be. It's not going to hurt them. It does not affect their quality of life, their longevity. And oftentimes this condition waxes and wanes. They may go months without a symptom, and then suddenly there'll be a month where they're having it daily. And oftentimes as time goes on, the condition just gets better and better, and it may actually resolve with time. So that's the idiopathic head bobbers or canine idiopathic head tremor syndrome. Then moving on from tremors, one of the next terms that we are wanting to try to use is peripheral nerve hyperexcitability. So this is referring to dysfunction of the motor nerve, and we usually think that it has something to do with an abnormality involving an ion channel, and very commonly the voltage gated potassium channel, that's what VGKC stands for, is implicated, that they have some sort of inherited abnormality with that channel that leads to fasciculations, myokymia, neuromyotonia, cramps, tetany, tetanus, etc. So I wanted to show you a video here of myokymia. So again, we're going to go to the Cornell website. So you can just see these little motor muscle depolarizations in this dog. And the interesting thing about myokymia and neuromyotonia is that these muscle contractions will continue during rest while the patient is sleeping, even under sometimes general anesthesia. They will continue. And then if with some disorders, like, we're seeing myokymia here, but sometimes they'll have neuromyotonia where, you get, much more generalized involvement of other muscles, they can actually be much more debilitating and make it hard for them to walk. And sometimes people describe them as like these vermiform muscle contractions affecting the flank or the hind limbs or the extremities in general. Myokymia or neuromyotonia, there are certain breeds again that we know are affected with this. This is, Jack Russell Terriers, Parson Russell Terriers, or other Russell related breeds, smooth-haired Fox Terriers, and we haven't figured everything out yet, but I did want to talk about hereditary ataxia, and it seems that these disorders are oftentimes they present together. So for example, the Jack Russell Terriers that may have hereditary ataxia will, in the majority of cases, also present with myokymia and neuromyotonia. So I do have a video. Now, this isn't going to show the myokymia and neuromyotonia as much, but it does show the gait disturbance and hereditary ataxia. And unfortunately, a lot of these guys, the prognosis long term is not favorable. There are some cases that maybe it's because they have a more mild progression that will live long term, but they can especially during like the myokymia and neuromyotonia events, they can overheat, and just due to quality of life concerns, oftentimes, don't live as a normal life expectancy. But we're just seeing the very exaggerated gait here associated with hereditary ataxia. But these guys will also then concurrently oftentimes demonstrate, other movement disorder characteristics like myokymia. And again, so far we don't have treatments for all of these disorders, unfortunately, but hopefully we will get there. All right. I wanted to move on to some further terminology for movement disorders, myoclonus. And this one probably you may have heard of. Probably the most common reason we hear the term myoclonus is actually from distemper virus. It's a very almost like many times pathognomonic movement disorder. So if I see especially like a young puppy, 3 to 6 months old, and they're demonstrating some of these myoclonic like jaw snapping behaviors or other movements that we're going to see here shortly in the video, it right away raises an alarm bell that I'm worried that this puppy either has or previously had distemper virus infection. But there are other, causes of myoclonus. And because of that, we're, some of the terminology that we're going to be trying to use going forward in the future is whether this is an epileptic myoclonus or non-epileptic myoclonus. So we do see myoclonic seizures. And there are certain genetic diseases, inherited diseases like Lafora disease, NCL. But then there's also some more like idiopathic diseases. Excuse me. And I came to use this term. It's not necessarily in the literature, but I see a lot of geriatric canine patients, older canine patients that start demonstrating these myoclonic movements, and they get more and more frequent over time. And we image them. We do brain MRIs, we do CSF taps. The only thing I've ever found is that, as expected in these older dogs, they do have some brain atrophy. But otherwise, everything comes back normal. But you put them on anticonvulsants, specifically levetiracetam, and they have an amazing or a wonderful response, much better than some of the other idiopathic epilepsy diagnoses. See, so this is what I was talking about with what I oftentimes see in some of my geriatric canine patients, in what we'll call kind of a epileptic myoclonus. So if we just watch for a little bit, that was a mild version. Coming up here will be a much more obvious version. So right there. So it's almost like they're getting like shocked a little bit. And this is, owners will describe this like they're going for walks, and they might do that like every 30 seconds, every, minute, as time goes on, they become more frequent. And then when that stops, they just keep walking. Like there's no other, it's just, and that's how I describe it. It's like they're getting jolted by something, and they really respond to levetiracetam very well. And so again, it seems like these guys are having some sort of epileptic, seizure, but it's more of a kind of a myoclonic, like a shock-like seizure. Then when it comes to, and luckily they respond great to Keppra. When it comes to non-epileptic myoclonus, a couple examples of what we might see or expect to see. So usually you see the myoclonus affecting the facial muscles like the jaw or the extremities. So you can see this puppy, and it's just this kind of rhythmic contraction of the muscles. Here it looks like the left rear leg, but Dr. De La Junta is going to put this puppy on its back, and you're going to see that it's actually both hind legs, and it's just very rhythmic. And they'll do this like while they're sleeping. And if they survive the active infection, the encephalitis, but they have myoclonus, unfortunately, it's typically a lifelong disorder. And I've had owners that have euthanized because they say that their dogs just cannot sleep. They just get woken up constantly. And then here's a dog, demonstrating the jaw chomping myoclonus or facial component. And it's nonstop. Some dogs, it's not as severe, and if they can sleep and so forth, I mean, if they can survive the active inflammatory stage of the encephalitis, they could live with this for the rest of their life. It's just, again, it's, you have to kind of make a determination on how much of an impact on their life is this having. You can certainly try. People have had some success with arrhythmia drugs. So procainamide, mexiletine are oral medications that you could send home for the owners to give. And it probably isn't going to resolve the condition completely, but it might lessen the severity. And I will sometimes give them lidocaine IV in the clinic to see if that's even a worthwhile try. If the lidocaine helps, then I'll probably prescribe them procainamide or mexiletine to give at home to see if we can at least decrease the severity of symptoms. And this is not we don't think that this has anything to do with damage to the brain. It actually has to do with damage to the motor unit, the motor neurons themselves, and the pattern generators within the spinal cord that have been damaged. It's not thought to involve the brain at all. Moving on to probably a much more familiar term to all of us. I think that there's been more work in this area, both from genetic standpoint, that we're starting to get discover genetic mutations, but then also one of the biggest helps has just been the cell phone, the smartphone. Now people can take videos of what's happening, and we can compare videos, and we realize that they're the same, so just the mapping of the genome, the smartphone have been really instrumental in progress in this arena. But paroxysmal dyskinesia literally means bad movement. It's oftentimes it's transient, and it oftentimes is severe enough that it impairs voluntary movement. Not always. Sometimes they're able to just kind of continue walking around while they're having episodes, but sometimes it's so severe that you'll see patients not be able to move, fall over on their side, kind of curl up. These episodes can occur at rest. They can occur during activity. Depending on the breed, the progression of the episodes, they can last minutes, but they can also last hours. So here is a soft-coated Wheaten Terrier having an episode of paroxysmal dyskinesia. And I find that this kind of happens where it seems to start in the hind legs, but it oftentimes will progress to involve the whole body, and they become unable to walk. And then once the episode is done, they tend to go on and move normally. So I think we have a different patient there. Here's just kind of going with the soft-coated Wheaten Terrier. I have another case. This was an interesting one. This one got sent to me. Granger, he's a 4-year-old male neutered soft-coated Wheaten Terrier. He got sent to me for seizures, and he got sent to me from a local surgeon. So Granger was a known epileptic. His epilepsy was very infrequent, maybe like 1 or 2 episodes a year. It was so infrequent that, no one ever started an anticonvulsant for Granger, but after the TPLO, he was having tons of episodes while he was in the hospital. So they sent him to me, determine whether we needed to start therapy now. Was there something else going on? Did we need to do advanced imaging? So this is Granger prior to the surgery, having one of these episodes. So, a pretty typical generalized tonic-clonic seizure. And I, understand why everyone thought that this is probably what was happening in the hospital. But given just talking to the owners in the exam room about what they witnessed during one of the episodes, it didn't sound like that, what was happening. And so here, it was just a weird case. This is where it comes back to signalment. So I have a younger soft-coated Wheaten Terrier who's demonstrating some involuntary movement, but the description didn't really fit with what we saw in that video. It kind of fit more with, this is Granger, kind of doing this sort of thing. So we actually decided, before recommending an MRI of the brain or putting him on anticonvulsants, we decided to send some blood. So whole blood. We could have done this with cheek swabs off to University of Pennsylvania and test him for the PIGN mutation, and he was homozygous affected. So this is, a test result that would make us think that this patient is going to develop paroxysmal dyskinesia at some point in their life, and probably that's what we were dealing with. And so instead of starting an anticonvulsant in this case, we decided to start acetazolamide. The first time we put him on acetazolamide, the owners reported diarrhea, loss of appetite, and they actually took him off of it. I think they also were complaining about panting. And so we actually, once those symptoms resolved, we restarted the acetazolamide, but this time we supplemented with potassium gluconate. And the patient Granger did much, much better, and he's still on it. And I just saw Granger for a recheck a couple weeks ago. I think he's had one episode in 2025, so pretty manageable. If he has one or two episodes a year and they're only lasting, a couple minutes, like that's pretty manageable. This dog is going to probably go on and have a happy, normal life. There is a paper describing the use of acetazolamide, and in that paper, there's a pretty wide range of doses, anywhere from 3.3 up to 11 milligrams per kilogram. You can do twice a day or up to 3 times a day. Granger's, he's like a 14 kg dog, and I'm giving him 125 milligrams twice a day. So he's, not as severely affected, I guess, and he's luckily responding to more moderate doses. The most common side effects associated with acetazolamide that are increased respiratory rate, so tachypnea. We believe that the tachypnea results from increased CO2 concentration, so hyperpnea within the blood, which causes acidosis. And so they're panting or breathing rapidly to get rid of that extra acid or CO2. It can cause sedation and diarrhea. That's been noted, but in my experience, the biggest issues have been the metabolic acidosis. Luckily, you can give them a over the counter. You don't even need a prescription for this, potassium gluconate, and that helps decrease the changes in pH within the blood, and therefore decreases the panting and so forth, and makes it much more tolerable for the patient. And right here, I just wanted to show this. This is from that ACVIM consensus statement. They've listed, breed-specific paroxysmal dyskinesias that we know about, and there's several pages here of different breeds that have been reported to have paroxysmal dyskinesias. And I'll be sure to make this PowerPoint available to everybody, just so you don't have to worry about writing anything down right now. But there's quite a few breeds that have been reported to have this. Now, not every breed has a genetic test available. Hopefully that'll change in the future, because it's very, very helpful if there is a genetic test available, rather jumping to a big expensive test. If our question is this a seizure or is this a movement disorder, it's so much better for everybody if we can do a simple blood test rather than starting with a several $1,000 MRI CSF tap. Just want to go through some other paroxysmal dyskinesias. There's hypertonicity syndrome or episodic falling. It goes by different names. Scotty cramp fits within there. First noted usually in very young patients, measured in months to usually within the first couple of years, you're going to see episodes. tends to be brought on by activity, excitement. They do luckily these patients seem to get better with time. And while we haven't totally figured out the mechanism of action, or I should say kind of the exact molecular reason for this movement disorder, we have seen in several papers that Prozac or fluoxetine helps. Now, there are other medications out there. People have tried anticonvulsants. They've tried clonazepam, and there's reports that might help, but fluoxetine seems to be the drug with reported to have the most success in treating this. And again, it may not cure them, it may not get rid of the disorder completely, but it can help with the frequency or severity. Let's look at an example here of some of these. It's a great resource, but a lot of these videos have come from the decades ago, so the quality may not be what we're used to, but and so luckily with these guys, they with the fact that they can get better with time, or at least the condition gets less severe with time, and the fact that we have a treatment that seems to help, at least these guys can do very well, and oftentimes do, in terms of longevity. And then he's done, and he's on his way. And so, like I said, sometimes we're lucky enough in the room that they'll have an episode for us in the exam room, just because I think they're so excited or they're stressed out. But if not, this is another, having something like this, if the client comes in with this video, this can be extremely helpful in allowing us to decide, how to move forward, because if they're not having an episode, their neuro exam is going to be completely normal. And without a really good description, or better yet, video, it can be very difficult to diagnose what's going on. So that's where the smartphone has really helped with the diagnosis and treatment of movement disorders. Okay. Let's see. And I wanted to, where do we go from here? And I think now that, one of the goals of the consensus statement was that we all start talking the same language, that we describe these events using more uniform language. But then also just with that, and with videos, and now with the mapping of the genome, hopefully we can start diagnosing, because we believe a lot of these have to be, inherited as some sort of genetic mutation, whether it's a recessive mode of inheritance or not. But, we would love to develop testing, commercially available testing for these. And there are, for some of them already, you can see here, these are lists of some of the movement disorders where we have identified the mutation. And if we've identified the mutation, there's probably a commercially available test that we can do for it. Here's some more. Just the middle column is identifying the actual mutation. Right. Okay. So I just, and I know there's a lot more movement disorders out there, but just wanted, I thought that was a good introduction to just the whole world of movement disorders. And, but I'd love to, open it up here and see if anyone had any questions, any experiences they would like to share, anything at all. So I'll open the floor up now.
Thanks, Dr. Moeser. I think one of the questions that I have is when most of these dogs have these movement disorders, do they experience any pain?
No, we don't think that they're, I mean, I should say, in some of the case, I'm sure there's kind of emotional distress in some of these, like they just can't move. With some of the things, like with the terriers, that whether they're experiencing hereditary ataxia or it's the neuromyotonia, if the muscle contraction lasts for a really prolonged period of time, it certainly can lead to hyperthermia and overheating, and that certainly could lead to discomfort. So I think part of the answer to that depends on how prolonged and severe of an episode is happening. And so for some of the disorders, I think they probably could experience some discomfort. But for others, we don't think that they're necessarily causing pain, as long as the involuntary muscle contraction isn't too prolonged, where they're experiencing buildup of lactic acid or breakdown of muscle, and they get myoglobinuria and so forth. So I guess it does somewhat depend on the duration and the severity of the episodes. But with some of them, I think, with with a case of, for example, the soft-coated Wheaten Terrier dyskinesia, especially with treatment, and if it's only lasting 30 seconds, a minute, I don't think those dogs are probably experiencing any sort of major distress. I'm sure they're emotionally kind of wondering, whoa, what is happening to me? But I don't know that they're necessarily experiencing pain. But then when you have a case where, if it's lasting hours and they're hyperthermic, and they're starting to get breakdown of muscle and so forth, that probably is more painful.
One of the disorders that you did not talk about, and I know that we're going to have some questions about, is CA. Can you address that?
Okay. Are you talking about like cerebellar abiatrophy?
Yes.
Okay.
Yeah.
All right. Sorry. Yes.
Yeah.
So yeah, and with cerebellar abiatrophy, I tend to kind of think of that a little bit differently sometimes, I think. But no, but I mean, it's very similar. So, and we think that with cerebellar abiatrophy, that either due to an inherited problem, like we know happens in the pit bull, again, where you can test them for the genetic mutation, or even potentially if they had an in utero infection and some of the cerebellar progenitor cells didn't develop normally, you're going to have certain gait disorders. But yeah, with cerebellar abiatrophy, oftentimes it shows up at a very early age. I think that the pit bull is a little bit different, where it sometimes seems to show up at a much later age, and is much more slowly progressive. And in those dogs, they oftentimes can live for years with the condition because it is so slowly progressive. Eventually, the gait disturbances become so severe that they're falling over so much they can't walk, that the owners will euthanize. With a lot of the other breeds that experience cerebellar abiatrophy, the symptoms will start when they're puppies, and it's much more aggressive, and it has a much worse prognosis. These dogs do not, in my experience, seem to have any sort of pain or discomfort. It's just a functional disorder. We can, and in addition, what's unique about cerebellar abiatrophy compared to some of these other movement disorders we've discussed today. With a lot of these movement disorders, if we do a neuro exam and if we do more typical neurologic testing, such as MRI imaging of the brain or the spine, CSF tap, a lot of those other patients, unless they're having a episode in the exam room, oftentimes their exam might be completely normal. And when we do our MRI, it's oftentimes normal. CSF tap is normal. One thing I will say, I mean, with cerebellar abiatrophy, they're always affected. Like it's once the manifestation of clinical signs starts, it's not episodic. They always demonstrate that, the hypermetric gait, for example, the cerebellar ataxia, the intention tremor. So we'll see that usually in the exam room. And then on MRI, one of the things that we will notice is atrophy, if you will, of the cerebellum. So, what we can see is, and I don't know if I have, let me look real quickly and see if I have an MRI example, but we will see the CSF, in the little, normally those sulci, the little folds of the cerebellum are so tightly packed together, you don't really see a ton of the cerebral spinal fluid on the MRI. But with cerebellar abiatrophy, as the brain itself atrophies, those sulci become much more prominent, wider, and you can actually see the changes on MRI. That now, if I see that change, it could still be cerebellitis, where they're having inflammation of the cerebellum due to an autoimmune disease or an infection. One of the big infections that we see causing that type of symptom would be Neospora in dogs. But now with some of these disorders, we can at least do the genetic testing too. So it is a little bit different with cerebellar abiatrophy from some of these other movement disorders, just based on the exam findings, and that we do oftentimes see changes on the MRI. And unfortunately, with cerebellar abiatrophy, whether regardless of breed, unfortunately, we don't have active treatments, and it does tend to be a progressive disorder. So in that way, it is similar to a lot of the other disorders.
Can you just define what you mean or explain a little bit more about the cerebellar gait?
Yeah. So we, in the world of neurology, let me see, I might have an example of a hypermetric gait, but we try to, there's three types of ataxia. There is spinal ataxia or proprioceptive ataxia. Now that's like your dachshund who herniates a disc, and they're knuckling on the tops of their feet. They are crossing their back legs. And then there's vestibular ataxia. Vestibular ataxia is, the best way I can kind of describe it is, kind of like a drunken gait. They are, falling to the side. Oftentimes it's to one side. They may have other, and I'm struggling to find the video right now, sorry, but they may have other symptoms of vestibular disease. They may have a head tilt. They may have nystagmus. And then there's cerebellar ataxia. So with cerebellar ataxia, oftentimes they have what we call a hypermetric gait. So the hypermetric gait, one of the things that the cerebellum does is it helps control it controls movements, fine movements. So like if you're reaching for your glass of water, if your cerebellum isn't working correctly, you're probably going to overreach, and then you're going to overcorrect. And that's kind of where we get the intention tremor. There's trouble with fine motor skills. And so when they're walking, they have this very exaggerated gait. Like they're picking their legs up in a very exaggerated manner. And it's, sometimes we talk about, it's almost like, sometimes you see the military marching and they have that very exaggerated floaty gait. So yeah, the best way I can describe it is just the flexion, the extension is exaggerated more than normal. So that's what we mean by hypermetria. And so that would be what we would describe as cerebellar ataxia, but just like vestibular ataxia. So as an example, sometimes we get pit bulls and mastiffs that come in and they have something going on with the cranial cervical spine, wobblers, a subarachnoid diverticulum, and they will demonstrate a very floaty gait in the front, especially, that looks hypermetric. And so we may have difficulty localizing that dog between C1, C5, so a spinal cord lesion between the first cervical and fifth cervical versus a cerebellar lesion, which is very important because we need to know where to scan. Do we scan the cervical spine or do we scan the brain? And so we do look for other abnormalities that are going to help us localize that lesion to the cerebellum. So we're going to ask the owners when they drink water, when they eat food, do they have like an intention tremor? Sometimes cerebellar dogs will have an absent menace response. Again, a menace response is where if I'm bringing my hand towards their eye, they should blink and retract the globe. And the menace response pathway actually goes through the cerebellum. So if they have something going on with the cerebellum like CA, they may have an absent menace. So there may be some overlap with other conditions, but a dog with cervical spine disease, I would not expect to have a menace response problem or intention tremors, things like that.
Okay, great. I'm just going to double check what a couple of messages that people have come in. Heather and Gail, because you guys have both had dogs with CA or do have them. Do you have any specific questions that you want to pose to Dr. Moeser?
And no, I think that there's no treatment is what I'm hearing. And I have a neurologist here, doctor at Blue Pearl in Minneapolis is my neurologist. I know where to go now for a second opinion, though. Thank you for being with us today.
Yeah.
Is it always progressive? My Augie is 3.5, and he kind of seems like he's always been. He was diagnosed before a year, and he kind of is what he is. Is it possible that he's just really slow progressing? I'm always worried about his longevity. What should I be looking for? What would be the signs that will it just continue to get worse? And what is that? If you could talk about that just a little bit.
Yeah, is Augie a Stafford?
Nope, he's a Scottish Terrier, and he's a purebred
yes,
Scottish Terrier. Yep, and he was diagnosed before a year. My vet knew right away that his gait didn't look right and sent us to a neurologist, and she knew right away what it was. And he's kind of been the same. He's about 3.5 years old now, and he hasn't really changed, which gives me hope.
Yeah, I think that's a really good sign. Now, did you guys do any sort of diagnostics?
Yes, she did all the full diagnostics on him, and it is CA. And we did the testing. It was not a virus or any of those kinds of things. Like he has the real thing. And she said, my neurologist has said that, not all of them are severely, it's a progressive disease, but some of them, just go a lot slower than others. And so we're hopeful. I take him about every 6 months. Yeah. So
oh, sorry about that. Yeah, no, it's really good to hear that you're not noticing progression, because there are certain some of the they're not all cerebellar abiatrophy is not the same. Each breed has may have a different underlying mechanism or mutation, and so if it's progressing slowly, that's great. And was there genetic testing that was done?
I've sent all
No.
of his blood in for, to be part of all these studies.
Okay.
So yeah, yeah. And I guess my last one, and then I know we've got other people here, is do you have any recommendation on food or supplements or any of those? Do any of that show promise, or is that just all kind of speculative?
Yeah, well, I guess the one thing I would say, going back, because my audio cut out a little bit. If we're not seeing any progression, this kind of goes back to maybe something happened in utero during development. Maybe it's not necessarily a genetic issue that's going to progress. Like the example I'm going to give is, so, cats that have abnormal cerebellar development during in utero, and they're going to have symptoms that localize to the cerebellum, and we tend to notice those symptoms as they get a little bit older and start moving around more, but it's not going to be progressive. And maybe something like that happened. You could have had an in utero viral infection or something that affected the germ cell line of a certain population in the cerebellum. So I guess my answer to that is maybe this won't progress if it's not truly an inherited disorder, but maybe something happened in utero. If it is genetic, what you would expect to see is just those symptoms, the hypermetria, that exaggerated gait will get slow, probably very slowly more pronounced. You may start to notice the wobbliness or the ataxia become more severe until they get to the point where they are falling over. But I would have to say I'm pretty optimistic, or I feel encouraged in your situation, that if you started noticing symptoms before 1 year of age and you haven't seen any progression through 3.5 years of age, that's really good news, and it makes me think that maybe it's not going to progress.
Okay.
In terms of supplements, diet, there's nothing that has been detected yet that would help with these conditions.
Okay.
Unfortunately,
Yeah.
I think just the most important thing is a well-balanced, nutritious diet. But my personal recommendation, I wouldn't spend a ton of money. I don't think there's any harm in trying some supplements, but there's no evidence that it's going to help.
Yeah. Thank you.
I'm going to speak up on my side. I also have a Scottish Terrier he is 5 years old. He was diagnosed about 1.5 years ago with the CA. And how it was diagnosed was I had a bitch who came into season and he went blind, and we took him in thinking it was the eyesight, and it ended up being a neurological issue. And they did an MRI. They put him on prednisone, which helped for a while, but we got him off and put him on the levofloxacin. Is that how you pronounce it?
Okay.
And that he has done really, really well. His gait has changed a little bit, but he maneuvers very well. He's become more engaged in the household, more involved in activities. I actually give him a couple supplements that are for anti-inflammatory, and I believe it's really helped him. He has not progressed. I believe it's maybe more on the slower side, which I'm hoping it stays that way. He's now about 5.5, almost 6.
Did you say that you've been giving leflunomide?
Yes.
Okay, and they did prednisone?
Yes.
Okay, it makes me so those are drugs that we usually are using for their immunosuppression effects. And it makes me wonder if in that, do you remember them saying that there was inflammation on the spinal tap or anything like that?
No, I don't. No.
Okay. Because that, I mean, that makes me wonder because we can see encephalitis affect the cerebellum too. And the most common reason for encephalitis in dogs is immune mediated forms of encephalitis. And the way we treat those is prednisone is a staple, but then prednisone by itself is usually not enough. So we usually have to give some other immunosuppressive drug, whether that's cyclosporine or chemotherapy drugs, leflunomide, cytosar, etc. But that's very interesting to hear that's helped so much. I'm glad to hear that.
It has, and he is not on the prednisone any longer because
Okay.
it almost got to the point where it didn't do much. And I saw a little bit of reversal, and that's when they changed the drug. And I've just seen he's been on this same drug for probably a good 8-10 months, and I've not seen any backtracking at all. I just feel I continually see his brain is sharper. You can, if you didn't know it, and because he's a retired show dog, and when you walk him like he walked as a show dog, you'd never know anything was going on with him. When you walk slow is when you notice the gait. Is there, it's off, you can tell. And he's a Scottish Terrier, so unfortunately, but and we have also sent in his DNA for the Scottish Terrier Club to do the help with the mutation of that also.
Okay.
Which I'm encouraged with how he's doing, that he hasn't progressed rapidly.
Yeah, I mean, and certainly Scottish Terriers, I mean, are one of the breeds. I mean, it tends to show up a little bit earlier than like pit bulls, but it, with the the reported abiatrophy, it does seem to progress very slowly, which is good. That's just interesting to hear how well he's done with those meds.
Yes, I'm
great.
I'm excited with that too. Yes. I also have a bitch who's what, 2.5, who we just got into the Scottish Terrier donor the DNA on Scotty Cramp. It's a family, it's a mother, father who are carriers, the brother's affected and the sister is unaffected. And they're taking that a step further with their blood. We just did it about 4 or 5 months ago. I'm so excited. We're getting so close to that it's huge. It's huge.
So, Gail, can you tell us the name of that medication again?
He's leflunomide.
It's a leflunomide, and I mean, I would just, it is a chemotherapy that we in neuro we typically use. So leflunomide.
Okay.
And we usually use it for suppression of inappropriate immune responses causing inflammation of the spine or the brain. But it has other oncology uses as well.
Thank you for that contribution, Gail. We have another question from Steve Miller. Steve, can you unmute perhaps and just ask your question?
Yes, Dr. Moeser, we had a Welsh Terrier that walked in circles, much like Bodhi did in your film that you showed earlier in your presentation. But he walked much faster than Bodhi and in tighter circles. And this could go on for hours. And at the time, we took him to a vet, and he said to us that this was the result of radiation treatments that he received on his nasal tumor. And we thought, well, yeah, that's it, plus age. He was about 15 at the time. And he had gotten the radiation treatments when he was 13, so 2 years had passed. And so now that listening to your presentation, I wonder if he had an additional neurological disorder, one of many you've described in this presentation, that it, maybe the radiation did play some part in it. Maybe the tumor came back. But I just thought I'd ask this postmortem now, gone this many years, but you've now brought this up, and I sort of like some closure on this whole
Yeah.
episode in my life.
So was it kind of like every day through, multiple times a day you would see him doing that circling?
Well, it would increase. It
Yeah.
started off just maybe once a week, then once a day, and then multiple times a day. And
Yeah.
we ended up putting him to sleep. We also did think that he was experiencing pain and discomfort, although from what you said earlier, maybe he wasn't. I don't know, but often felt bad that I didn't do more in his later years.
Did he ever do anything like put his head up against the wall, get stuck in weird places like the
Well,
corner of a room?
he would get lost sometimes. He had we never really put him in a crate, but he did have a crate next to a this large plant, and he'd sort of get lost behind that plant.
Okay.
And then, then he'd kind of snap out of it. So it wasn't a constant, like, I don't know where I am, but it was periodic. So, we did think there's just so many issues, physical, and, he was starting to lose control of his bowels. That was another issue.
Yeah.
But I didn't know along the line, maybe he had a neurological disorder, much like Bodie that you showed, or some other dogs that you showed in your.
Yeah, I would be worried at that age with the frequency of circling that you were noticing, even pain. Like, I don't know if he was holding his head low, getting locked, kind of stuck behind the plant. When we see like repetitive circling like that, one of the more common reasons for it would actually be a structural encephalopathy, meaning that if we did an MRI, like we did with Bodie, we would actually find something. We didn't see anything with Bodie, but that's one of the reasons we looked, is because of the circling and things that we were looking for in a 13-year-old dog. One of the biggest things would be a tumor. And I would be concerned in that case, did the nasal tumor spread to the brain? If, with things like nasal adenocarcinoma, they can break through the cribriform plate and go into the brain, or some other tumor, or even something like a stroke. So I think that at that age, a movement disorder would have probably been less likely. While the radiation certainly could cause damage to the brain, it's pretty uncommon. Just the radiation oncologists are pretty good at, preventing unintended exposure of normal tissue, especially the brain, to too much radiation. So I unfortunately would have probably been more concerned about some sort of tumor, either metastatic from the original or spread from the original nasal tumor, or some sort of primary brain tumor. But I'm sorry for your loss.
Okay, thank you for explanation.
Yes.
Thank you, Steve, for contributing to the discussion. For those of you who may not be aware of the fact that Gail and Heidi both mentioned about the DNA bank. So The Health Trust Fund of the STCA, of which I'm a trustee of, has existed for more than a couple of decades. And part of the question from a lot of people is what exactly does that group do? And we are just in the process of launching an independent website so that it's going to be easier to find information related to health issues on the Scottish Terrier breed. The biggest thing I think that trust that the STCA or that the Health Trust has done is about 3 years ago, we made a huge effort in terms of collecting samples of blood from Scottish Terriers all across the US. Show dogs, companion dogs, dogs that came from puppy mills, dogs that came into rescue, we don't know their background, etc. We have almost 1,000 samples of blood that have been collected and are stored in a repository, which is now in the state of Indiana. Part of what Gail mentioned and Heather mentioned is that their samples have been chosen to be participating in a couple of the ongoing research studies that are going on right now. And the one on Scotty cramp is involving dogs from multiple generations, and we're getting close, very close to identifying what the factor is there. And then the hope ultimately is to be able to get a genetic test developed. And we've got some studies going on with CA as well. So if you've not participated in submitting your blood to that DNA bank, stay tuned. Or if you live near a regional club, a regional STCA club, or a rescue group, we will be probably launching some additional blood draws in the future. The difference now being that we've got to get those blood samples sent in overnight, and it's very expensive to do that. So we're going to be looking to do collections from groups rather than individuals, because literally an overnight submission of that sample is going to be 50 some bucks at least, via FedEx. So just stay tuned for that information. Erica Cerny, who does rescue out of New York, just sent a video tip, and I don't know if I'm going to be able to bring this up here or not, but I think what it is looks like to me, Adam, is similar to the one that you showed earlier. I'm going to just click on this and see if we can show
I
it.
hope that works. I'm not sure I copied it, but who
Got it.
knows what it is.
Got it, I think.
Okay.
Oh, that was very quick. Hang on a second.
It's quick. I think it's quick. She sent me 3 quick ones.
Yeah. So it looks like she gets up, moves, and then sits down. Is that correct, Erica?
Yeah, that's what it looks like.
So Adam, what's your take on that?
And did I miss the video? Did it pop up?
Yeah.
Let me see why. Hold on one second here. If I can.
I can see the link, Michelle. The link is in our comments or in the
Hang on one
chat.
second.
There's a link in the chat, but I didn't see it come up on the screen.
Yeah, hang on one second. I have to figure out how I'm going to do this.
I can click. Let me click on that link real quick and see.
Okay, yeah, then you'd be able to see it.
Okay, let me see here.
I just got 3 in an email that are all real quick ones. So I tried to copy the one over here.
So is this like after that he's kind of sits down, like then what happens? Does he get back up or?
Well, that I don't know. I think what happens is the dog is walking normally, and then all of a sudden, and this just started at between 5 and 7 years old. So the dog is walking normally, and then all of a sudden starts walking like that, like it almost seems like she can't stand up on the back legs or one of the back legs, and then just sits down. And then I think eventually, I saw the videos a while back and I thought, well, maybe it's Scotty Cramp or CA, but it wasn't there when we placed the dog. and it wasn't there for years. So I didn't think it could be CA unless she was born with a very light case that all of a sudden started progressing. But the cramp usually I see in a younger dog, and it's so, it wouldn't start that late, but it seems like
Yeah.
she will cry like she's in
I,
pain. And she's had
yeah.
all those tests done, all those very expensive tests, and they didn't find anything. So she just told me, we just cannot find out what's wrong with her. We're just giving her Rimadyl and it seems to be helping. But I think that after watching your presentation, I'm wondering, is this some other kind of gait issue, like a paroxysmal, or could it even be a seizure?
I agree. Like, I know it's a very brief segment. I don't see anything on that video that would make me be concerned about CA. I'm not seeing anything that localizes to the cerebellum. And it would be very unusual. I mean, again, normally we would expect symptoms to be improving or becoming less severe with time, maybe not show up so late in life. So when you say they've done all of the diagnostics, like they did MRI or just?
I'm not positive. I know they were looking to do an MRI. I know that they were doing a spinal tap. I know, so they've been going through with a neurologist. That this is in Rhode Island.
Because I would be more concerned that there's either something orthopedic that's causing pain, whether there's a cruciate tear or something like that, or something causing pain and involving maybe like the lower lumbar spine, whether that's a disc herniation, something along that. Just, and I know it's 2 seconds long, so I'm probably saying more about that. And if they want to take a longer video and I can make my email available. I'd be happy to look at it.
That would be wonderful if you could just take a quick look and tell me what you think. I can also have her make a list for me again of what the tests were that they did, so you would know what
I'm gonna put my email address in the chat.
Okay, thank you.
And then I was gonna say, like, the fact that Rimadyl is maybe helping again makes me think that this is not necessarily a movement disorder at all, that we're probably dealing with something that's causing pain, either orthopedic or neuro.
Okay. I will definitely contact you about this.
Any other questions? Because we're at just a little bit after 11, so I think I'm going to close our session here. Thank you so much, Adam, for doing this presentation for us. It's been very helpful, and the samples that you pulled out, really, really helpful. I appreciate it greatly. I will be sending you an email giving you your choice of some Door County coffee or a certificate from the Door County Scotland Yard Bed and Breakfast as a thank you from Door County Scotty Rally. So thank you all for tuning in. This will be posted on our website by tomorrow, by the end of tomorrow. And for those of you who were wondering about last month's presentation, there was a challenge with the audio has been obtained, but for some reason the video did not show up. So I'm trying to work on getting those two synced. If that doesn't work, you'll see the audio and the slides separately, and you can just kind of sync those yourself or listen to them while you're flipping through the slides. So thank you very much to everyone. Remember, you can make a donation to Door County Scotty Rally directly via our website. Just go to doorcountyscottyrally.org and you'll have that opportunity to do that to help support this programming. Again, Adam, thank you very much for your Saturday morning time. We appreciate it.
Thank you.
Thank you, everyone. This was fun.
Thank you.
Bye, everyone.
Bye-bye.